Test 1 2 1 2. Test test test. Test 1 2 3 1 2 3. Test 1 2 1 2. Test test test.
Okay, I'm going to go ahead and get started. I'm Dr. Hedberg. I work at Bradford Health Services. My specialties are psychiatry and addiction medicine. And what we're going to talk about is psychiatric issues for primary care. One of the biggest problems we have in the United States is that the supply of psychiatrists is nowhere near the demand. And often primary care physicians are kind of forced into the position of having to treat psychiatric illnesses even though they haven't been in a formal training program. And as far as disclosures, I have no disclosures. I wish I had some disclosures. It'd be nice to have some extra income, but that's not me. So we're going to talk about some of the common diagnoses that are seen in primary care, which ones lend themselves to being able to be treated in a primary care setting, which ones should be left for the psychiatrist, and disorders to refer for just therapy. And I'm going to start out with depressive disorders. It's probably the most common thing that a family practice physician or setting will encounter. And there are different degrees of depression. Major depression disorder is what I'm going to mostly talk about. Some people have a chronic low-grade depression that doesn't quite meet the criterion for a major depressive episode, but they have symptoms that last a long time. For that diagnosis, the depression symptoms have to be present for at least 2 years and not absent from symptoms for as much as 2 months. Another topic is the premenstrual dysphoric disorder, and then substance-induced depressive disorders. And there are a number of risk factors for depression. One of the kind of interesting one is death of a parent before the age of 11. Very high incidence of depression among that group. Right along with that is childhood abuse, whether that's physical or emotional or verbal. Certainly sexual will have a high incidence of depression and actually anxiety. Unemployment is a big trigger. Retirement is a big issue. I think it's one of the reasons why doctors never seem to retire. They might be afraid they're going to have depression once they quit. What am I going to substitute for my workaholism? Loss of a spouse. Genetics plays quite a bit of a role. There's a 2 to 3 times increase in depressive disorders among relatives who have depression. They looked at concordance among twins. If they're dizygotic twins, be more like siblings, there's a 20% concordance. But if it's identical twins, if one twin becomes depressed, there's a 50% chance that the other twin will have the same disorder. They've also done adoption cases and looked at the inheritance patterns there, and the incidence of depression is much more relative to the history of the biologic versus the adopted parents. Some of the statistics, the lifetime prevalence of depressive disorders is at least 17%. If I had to guess, I would say it's actually higher than that. And it's disproportionately women. The average onset, 29. So this generally occurs relatively young in life when the first episode happens. 60% of the time, the symptoms are bad enough that it really affects the roles, whether that's at home or at work or school. People who do have depressive episodes, 5 to 10% later will have a manic episode, and that changes the diagnosis to bipolar disorder. This is a really important statistic and reflects the need for treatment. Obviously, completed suicides for people who have a history of depression is up to 15%. The duration average of a depressive episode is 3 months. By 6 months of treatment, about 60% will be in remission. If they're treated over a longer period of time, about 2 years, some people feel that it's as high as 80%. I think that's probably too high. I think in terms of more like a third will have treatment-resistant depression, which is much harder to treat. The risk, I basically tell my patients, if you've had one major depressive episode, there's a 50% chance you'll have another major depressive episode. If you've had two depressive episodes, it's up around 70 or 80% chance that you'll have another depressive episode. Once you cross 3 or 4 depressive episodes, it's not are you going to get depressed, it's when and how bad. And those are the folks that we would want to get on a medication, hopefully get them into remission and leave them on the medicine, continue to treat. And there's a pretty high incidence of other psychiatric disorders with the depressive disorders, anxiety being the number one symptoms. And anxiety and depression really go hand in hand. And to make the diagnosis of a major depressive episode, you have to have 5 symptoms that persist for at least 2 weeks. And in reality, if I had a patient that just was depressed for 2 weeks, I'd kind of be reluctant to treat that. Generally, the patients that are having really significant episodes, it's weeks to months that they're depressed. And a lot of times it's weeks to months before you see them. And they have to have 5 symptoms that occur at some point. A depressed mood, not interested in doing anything, nothing's fun, the appetite changes, people either can't eat or tell you that food just doesn't taste good and they have no appetite, or they overeat to kind of soothe. Most everybody has some sort of sleep disturbance. Most commonly, it's they can't sleep. They're tired, but they can't sleep. Sometimes patients are just sleeping all the time. It's like their defense mechanism and it's an escape for them. There's often psychomotor retardation. I see that more than the agitation, but some people get very agitated when they get depressed. Most everybody will say that they feel tired, and they're really good at beating themselves up inside their heads. A lot of times I'll ask patients, if you talk to your friends like you talk to yourself, would you have any friends? Because they're really good at being hypercritical of themselves. It can affect their concentrations, and if they're having, there's a big difference between passive thoughts of death and suicidal ideas. Almost everybody at some point in their life hits a really tough situation, and the thought comes to themselves, like, if I don't wake up tomorrow, it'd be okay. That's a passive thought of death. And it's a huge difference between I'm really thinking of killing myself and I'm going to go buy a gun or formulating a plan. So I don't get real hung up about somebody that says, yeah, if I just didn't wake up tomorrow, it'd be okay, versus, I'm getting serious and making a plan. And there does have to be a distress and impairment of function. Basically, people have to not be functioning at their normal, whether home, work, school, wherever. And one of the things that you can do in your office is the Hamilton rating scale for depression. It's called a HAM-D. Is available on the internet. You can print it out, and it's an easy test that you can give to the patients that they fill out. And it rates a number of different things that load onto depression. It has scales for how much your depressed mood is affecting you or how much guilt feelings you're having. It specifically addresses the suicide ideations, insomnia, how's it affecting your work? Is your weight changing? Are you agitated? How much anxiety are you having? Is your libido down? Is there psychomotor retardation? And it scores for you, so you pretty much have a good idea of whether or not you're dealing with a depressive episode. And some of the things I ask patients, especially when you're kind of on the fence of do they really have a depressive episode, I ask them, when you get depressed, are you down for hours, days, weeks, or months? And a lot of times people will say, yeah, I'm down for a few hours or maybe a day or so. Well, that definitely doesn't qualify. I really want to hear that they're down for weeks or months before I start looking at medicines. Although I do ask if you have down days, it's normal. Everybody has down days. That's normal. But do you go through periods where you're having more down days than good days? And if that's the weeks or months, then that trips my wire for treating a major depressive episode. And then I ask them some questions that will have to do with what kind of medicine I choose. The first one I ask is, are you having more trouble with sad and blue feelings? Or are you having more trouble with no energy, no motivation, can't get yourself going? Or are they kind of equal? Or is it just that nothing is fun? And then we talk about how much anxiety are you having. And one of the things that you all as primary care givers would want to think about is thyroid functions. It's a common cause of a depression, and it's fixed in a different way, obviously. So depending on what people tell me, what kind of symptoms they're having, I either choose a serotonin agent, any of the serotonin reuptake inhibitors, and that gets at the sad, blue, and anxiety symptoms best. On the other hand, if they're complaining of no energy, no motivation, can't get themselves going, or both, sad and no energy, the no energy is a norepinephrine function. So for those patients, I would pick a serotonin norepinephrine reuptake inhibitor. And those are medicines like the venlafaxine, which is Effexor, duloxetine, which is Cymbalta. Desvenlafaxine is the newer Effexor called Prestique. It's now generic, so it's affordable. The newest one is Fetsima. So you need to check and make sure that their insurance will cover that one because it's expensive, $400. Another symptom that I look at is it just nothing's fun, and that has to do more with the with dopamine function and the pleasure reward areas of the brain. And the one medicine that does affect dopamine is Wellbutrin. It also is a norepinephrine reuptake inhibitor. And then I really want to talk about how you dose people. The single most frequent mistake I see with patients that I get that have been treated in a primary care setting is people are started on a starting dose of an antidepressant, but they're never moved to the maintenance dose. It's frequent that I'll get somebody that has been put on Zoloft, for example, and I ask them, you're at 50 milligrams. How long have you been at 50 milligrams? And they'll say 6 months. Well, I wouldn't expect it to be effective at 50 milligrams. Really, you're going to need to get to 100 milligrams of Zoloft for it to be effective, or even higher if there's anxiety symptoms. So here are the starting doses. Maintenance, thinking more in terms of 40 milligrams, maximum dose of 80 milligrams. Paxil, 20 milligrams. Paxil you can go up to as much as 40 milligrams. Zoloft you can go up to as much as 200 milligrams. You probably know that Lexapro is essentially Celexa, but it's just the right-hand isomer of Celexa. So I feel that it's more effective. If you're going to treat it, for depression, some people respond at 10 milligrams. If there's an anxiety component present, you really need to get to 20 milligrams before it'll be effective. Trintellix and Vibrid are the newer serotonin reuptake inhibitors. Started at 10 milligrams, both of those. You can go up to as much as 20 or 40 milligrams for those medicines. And again, the serotonin reuptake inhibitors are predominantly for people who have sad, blue, anxiety symptoms. The ones that are having trouble with no energy, they can't get themselves going, they're not motivated, my first choice is generally Effexor. And the starting dose is 75 milligrams, but I move everyone after a week to 150 milligrams. It's a much more effective dose. The maximum you can go to is like 300 milligrams. Prestige, 50 milligrams is the starting dose. It's nice that a lot of people, that's the maintenance dose too. You really don't have to go up on that. However, you can. I rarely go more than about 100 milligrams though. Cymbalta, you start at 30 milligrams, after a week 60 milligrams. One of the unique things about Cymbalta is that it can also help with pain. But in order for you to be effective for someone who has chronic pain, you've got to get it to 120 milligrams. And I usually give that in 60 milligrams twice a day. But our patients that are having pain, they tell me that really does help. Fetsima is another newer SNRI. You start it at 20 milligrams, but for only 2 days before you go to 40 milligrams. Again, the maximum dose is 120. And then Wellbutrin started at 150, but after a week, go to 300. And maximum dose is 450. And then the next biggest mistake I see is that a lot of times people get put on a starting dose and then they're followed up at the regular interval you would for medical problems, which might be next year. So, one of the issues is even if you're trying to get them into a psychiatrist, it's probably going to be 3 or 6 months before you can get them in there. I'll regularly hear patients say, yeah, I tried to get into a psychiatrist and, the waiting list was 3 months long. So you really need to see these people in follow-up at least by 4 to 6 weeks. And this is after they've gotten to the maintenance dose. The other problem that you have is that even though you would like for some people to go to the psychiatrist, they're never going to go. They're just too resistant to the idea of seeing a shrink. And for those folks, you may need to increase the doses. Then if you have a patient that they won't go to the psychiatrist or you can't go to the psychiatrist and what you're doing just isn't working, there are a number of tricks that you can do. And the first thing I would think about is combining more than one agent. And generally my go-to for the next agent to add is Abilify. Somewhere between 2 and 5 milligrams. And a lot of times that'll kick people into more of a remission. And Abilify hits a number of different receptors. Other medicines that have been studied that do the same kind of thing, Seroquel, quintiapine, anywhere between 50 and 300 milligrams. You definitely want to give that at night because it's pretty sedating. Abilify is also given at night. And I like Abilify because it's weight neutral. Most everybody does not gain weight on Abilify, but Seroquel is pretty much guaranteed weight gain. And then the new one is Rexulti. 0.5 to 1 milligram, you really need to check and see if the insurance is going to pay $1,200 per month. I'm sure that they're not making money on that. You can combine a serotonin reuptake inhibitor and a a serotonin norepinephrine reuptake inhibitor with Wellbutrin. That way you're kind of hitting all three neurotransmitters that are involved in depression. Serotonin, norepinephrine, and dopamine. If people are having a lot of trouble with fatigue and they can't get out of bed, something like Provigil, modafinil, 200 milligrams can really help and boost the antidepressant effects. There's a population of people who have a problem with folate. Folate that you get over the counter does, for some people with depressive disorders, they don't seem to be able to get the folate to cross into the brain and form L-methylfolate. And it's L-methylfolate that is the precursor for serotonin, norepinephrine, and dopamine. So if they are one of those folks that just doesn't get the methylfolate into their brains, if you give them methylfolate, then they have the building blocks to actually raise the levels of their serotonin and norepinephrine in the brain. This is something I frequently give people. It's over the counter, but it has to be the L-methylfolate, not just folic acid. Buspar affects the dopamine receptor some. It can boost the effect of another antidepressant. Remeron is another one that we can combine with either the serotonin or norepinephrine reuptake inhibitors. It's especially good for people that are having difficulty sleeping. It is sedating, but one of the problems with Remeron, and one of the reasons I don't use it very frequently, is because it makes people really hungry and they gain weight. And the final one I'll mention is lithium. Just in mentioning this, it's really the only medicine that we know of that actually decreases suicidal ideas. But if you've got somebody that you needed to put on lithium, you probably don't want to be treating them to send them to a psychiatrist. And the next question is, well, how long do you treat people? And to make an adequate trial for an antidepressant, they have to be on their antidepressants for at least 6 to 8 weeks and probably at a pretty healthy dose before you say it doesn't work. And if you have somebody that's on an antidepressant that is working and they're in remission, the minimum time they should be on the antidepressant is 6 months. Most people say more like a year. Kind of one of the easy things I say to my patients is, once you're doing well, give the medicines at least another 6 months before you try coming off. And basically I tell them, we'll try coming off, but if you crash and burn, we got to start it right away again, and that would be episode number 2. If you crash and burn 3 or 4 times, you just need to be on the medicine. And then there's the group that you probably don't want to treat, and that's the 1/3 of patients that you just don't do well, the treatment-resistant people. And the commonly accepted definition is a failure at 2 different antidepressants, and it really needs to be of different classes. If you put somebody on Prozac and then switch them to Zoloft, you've really just given them the same type medicine twice. And it's those folks you definitely want to try to get them into the psychiatrist, because they can be really difficult to treat. And then, for people who we recommend that they just stay on the antidepressants are the folks that have had 2 or more major depressive episodes, or if they've had 2 episodes and they have a really strong genetic loading. If there are other people in the family, or they had early onset or really severe episodes. And basically what you do is leave them on the dose that works. And some people just kind of have to accept that I do fine on an antidepressant, I crash and burn off an antidepressant, and it's no different than treating hypertension or diabetes or any other chronic disease. You need to accept that you need to be on the medicine. Now, a different category is bipolar depression. The diagnostic criterion for the depressive episode is essentially the same as for major depressive episodes. But if someone has bipolar disorder, you're going to use a different set of medicines. And the medicines that are approved for depression in bipolar disorder, the Symbyax, which is olanzapine, and fluoxetine, that's Zyprexa and Prozac. I really don't like it because it's a combination. It's harder to adjust doses independently. Seroquel is used for bipolar depression. There are good studies that show it works. The problem with that is that they're going to gain weight. So the one I like to use is Latuda. We don't have the weight problems. They have less side effects. You started at 20 milligrams, but you're probably going to have to get to 80 milligrams, maximum of 120 milligrams. We generally don't use the regular, ordinary antidepressant medications. There's some controversy about it, but some people believe that the regular antidepressants can push someone into a manic episode. And there are other folks that really don't believe that the standard antidepressants really work. It's just the person comes out of their depressive episode kind of like they would naturally. The other medicine that I start on everybody with bipolar depression is Lamictal. And Lamictal, you have to be really careful with how you dose that. If you go too fast, people tend to get a rash. And of course, the real serious side effect that you're worried about is Stevens-Johnson syndrome, which I've never seen, but I've read about. So what's recommended in psychiatry for Lamictal or lamotrigine is 25 milligrams for 14 days, 50 milligrams for 14 days, 100 milligrams for 7 days, and the target dose is at least 200 milligrams. And you can go up to 400 milligrams on that. And what I generally do is I start Lamictal and Latuda. The benefit of Latuda is that it also will help prevent manic episodes. So you're kind of killing two birds with one stone while you're trying to get them out of their depressive episode. And another mistake I see a lot, and this is, psychiatrists are guilty of this as much as anybody else. A patient comes in and says, I got mood swings. And they say, okay, you're bipolar. Well, mood swings are mood swings. They're not manic episodes. And if somebody comes in saying, I've got mood swings, my first thought isn't bipolar, it's borderline. Anyway, it has to be a distinct period of abnormally elevated or agitated mood. It has to last 7 days nonstop. And during that time, they think they are really hot stuff, and they are going to make big plans to be rich and famous. They are not going to sleep much because they can't, because they have too much energy to even think about sleeping, and they are not tired. And one of the things when I'm going through symptoms with patients, a lot of times, I go through times when when I'm not sleeping. Well, there's a huge difference between I'm tired and I want to sleep, but I can't sleep, and I've got so much energy I don't need to sleep. And that's what the manic folks are like. Thoughts are racing on them, or flight of ideas, and they're very distractible. They're talking more than normal, louder than normal, faster than normal, and when you're talking to them, you cannot get a word in edgewise. They will bust into the middle of your sentence and be off to the races on 3 different subjects. And they do stuff like spend money, have sex, do business stuff that they regret later. Part of the diagnosis is that it has to have marked social or occupational impairment. They are not doing well, and they may be hearing things, seeing things, or getting really paranoid. And people can get paranoid pretty fast, pretty bad. It was interesting, one of my first experiences on the first month of my psychiatry training was on an inpatient ward. And we were sitting at a kind of place like this, and I was talking to my resident friend, and this guy came up and just punched my friend out. And he thought we were talking about him. He was manic and having paranoid delusions, and felt sorry for my buddy, but I sure was glad it wasn't me. So if you have someone that's looking like this, you want to get them out of your office and to the hospital. Okay, another subject, premenstrual dysphoric disorder. This one has to have 5 or more symptoms: mood swings, sadness, tearful, irritable, angry, conflicts, feeling hopeless, real down on themselves, self-critical, a lot of anxiety. Has to have 5 or more symptoms, and at least one of these are the 5 symptoms. Decreased interest in normal activities, poor concentration, appetite changes, can't sleep, feeling overwhelmed. And it has to be most cycles over the period of a year. And treatment, the serotonin reuptake inhibitors are the first-line drug for that, and there's some evidence that Zoloft might be the most effective one. At minimum, it needs to be started a week before the onset of menses, which almost doesn't make sense to me. I would think it'd just be much easier to put people on the Zoloft and leave them on it. Contraceptive medicines can help, and then there are therapy things that people can do to help. Learn relaxation, stress management, exercise really helps. Cut down on caffeine, alcohol, and tobacco. Cognitive behavioral therapy, family therapy, or maybe the family just needs to take a vacation once a month. Okay. All right. Generalized anxiety disorder. This one kind of drives me nuts because it seems like everybody in that comes in my office has more anxiety than is normal. But the reality is that true anxiety disorders start very young. It's really evident by early in childhood. It's the kids that are extremely shy. They have 1 or 2 friends that they associate with. They're in the back of the room. If it's a party, they're on the wall. They don't do things that would make them on center stage. They don't seek attention. So if you have somebody that was voted most popular in high school and was the homecoming queen, they probably don't have an anxiety disorder. There's something else going on in their life. But to make the diagnostic criterion, it has to be excessive anxiety and worry for at least 6 months with at least 3 symptoms. It makes them feel restless or on edge or keyed up. It wears them out. They have trouble concentrating. They have muscle tension, especially neck and shoulders, and difficulty falling asleep because they just can't turn their brain off. And one of the things I ask them is, do you feel like you really have that more anxiety than others would have under your circumstances? Because a lot of people are under a lot of stressful circumstances that would produce anxiety in anyone. So sometimes it's really hard to tease out what's really a generalized anxiety disorder. Social anxiety disorder is a little bit different. At home, they do just fine. They're not nervous and anxious all the time. But if they have to get out and do things in public, especially if it's meeting people they're not familiar with, or maybe even just eating in public, certainly performing, they're very anxious, and they're afraid that people are judging them. They're afraid that they're going to do something that looks silly or makes them look stupid, and it provokes tremendous anxiety just to get out and do kind of ordinary things. And they avoid being out. You know, they're the kind of people that say, I shop at Walmart at midnight because there are not many people there. And it has to last at least 6 months. And you need to specify whether it's just something like public speaking. A lot of people are petrified of that but do okay in other areas. But this is another one. Average age of onset is real evident by early teens. So it goes along with the, anxiety disorders start out pretty early in life. And then there are panic disorders, a recurrent, unexpected, abrupt surge of intense. Most people will say, I thought I was having a heart attack. And a lot of people will go to the hospital the first time they have a panic attack because it feels like it. Their heart's pounding out of their chest, they're tachycardic, they can't get their breath, they're shaking, they're sweating. They complain of either pain or chest tightness. A lot of people will have abdominal symptoms, get lightheaded, and then feel that things are closing in on them and they have to get out of wherever they are. And a lot of times they'll just rush out of the Walmart or wherever they are. They could have paresthesias. Some people think they're going to go crazy or are going to die. And it's pretty scary situation for people. So what do you do to treat those anxiety disorders? Don't use benzos. The studies originally done with benzodiazepines for anxiety disorders were done for 10 weeks. Well, for 10 weeks, benzos will beat everything. Later, they did studies that compared to benzodiazepines and things like serotonin reuptake inhibitors, but they looked at them 2 years later. And the folks that were on benzodiazepines actually reported more anxiety, whereas the people on serotonin reuptake inhibitors had less anxiety. And basically what happens is it works, and then it stops working, and they increase the dose, and that stops working, they increase the dose. And then every time their blood level drops, the first symptom is anxiety. It's a withdrawal symptom. It's the first and most dramatic symptom of your benzodiazepine level dropping. The other phenomenon that happens is that if somebody has been on a benzodiazepine for a good period of time and you try to get them off, they have rebound anxiety for at least 3 to 4 months, which is worse than what they started with. So I've done psychiatry for a long time. I almost never use a benzodiazepine, and if I do, it's for a few weeks, maybe a month, but that's it. So the first line drugs are the serotonin reuptake inhibitors. You can also use the serotonin norepinephrine inhibitors, especially if there's a depression component. There's some evidence that Trintellix might work better than some of the others, but the real trick is that you got to get the dose up. You just literally, you have to use higher doses, usually twice the maintenance dose, to be effective, and it takes time. You don't give up on a serotonin reuptake inhibitor for at least 8 weeks. The other thing that you can do if you want to start something now to help with anxiety that works quickly, Neurontin works really well, gabapentin, 100 to 300 milligrams 3 times a day. It works on the GABA receptor, and it really does help with anxiety, especially the worry part. Lyrica does the same thing, 50 milligrams 3 times a day. A lot of times if people are real nervous, jittery on the inside, stomach in knots, chest all tight, I tell people that when you're nervous and anxious, you're putting out a lot of adrenaline. And the beta blockers like atenolol will block some of that nervous, jittery on the inside feeling, which kind of decreases their overall anxiety. And you can use 25 to 50 milligrams twice a day. They will have to take their blood pressures though. And I especially use atenolol if there's any question of depression, because it doesn't cross the blood-brain barrier. You can use propranolol, but not in depressed people, because propranolol definitely can cause depression. If they have not been on a benzo, Buspar, it works pretty well. If they have been on a benzodiazepine, Buspar just doesn't work. I would go with either gabapentin or Lyrica. And then low doses of Seroquel can also help with anxiety. Okay. Obsessive-compulsive disorder is tough to treat. People have obsessions, especially germ phobias or cleanliness or cleaning, and they're recurrent, persistent thoughts that they try to suppress or ignore, but they just can't, and they're compelled to do those things. And various checking or watching or behaviors, and at least subconsciously or consciously, it's to reduce stress or to avoid something bad happening. And the real key for obsessive-compulsive disorder is it has to take up at least an hour or more a day of a person's time. If it's just, I like to turn off the light switch two times, or check that the front door is locked 2 times or 3 times. That's not rising to the level of obsessive-compulsive disorder. It has to be causing distress, and generally it starts young. Another anxiety disorder that starts young, usually in adolescence. And interestingly, the prevalence is the same worldwide. And apparently there's a lot of inheritance, because identical twins, 80% concordance. And on OCD, you really have to get the doses up. All of these are pretty high doses. Prozac a lot of times is easier to get it up to that 80 milligrams. But all of these, the problem is getting the dose high enough without having too many side effects. And then there are other things you can add on if the serotonin agents aren't working: Risperdal, Zyprexa, or Pendolol, which is an alpha and beta antagonist. But equally important is the cognitive behavioral therapy. Therapy helps, medicines help, but for the people with obsessive-compulsive disorder, you really got to convince them to go to therapy, where they learn different techniques to help deal with their OCD symptoms. And actually, for all of the mood and anxiety disorders, medicine and therapy work better than either one alone. So it's pretty important. Post-traumatic stress disorder, gee whiz, I'm not going as fast as I thought. Post-traumatic stress disorder, one of the things that I run into is people want to have this diagnosis, and, have you had any trauma in your life? Yeah, my grandmother died. Well, that doesn't make it. It really has to be actual or threatened death or serious injury, or you witnessed it. Possibly it happened to your family member, or another whole category is the folks that are the first responders, police officers, emergency squads, that come in contact with a lot of physical harm to people, or the military. And they have intrusive thoughts that come into their brain unwanted, and they can't keep them from coming in. They try to avoid anything that reminds them of those things. And then they have negative cognitions about themselves, where they feel like a bad person, especially if they've been sexually abused. And they have hypervigilance. Cognitive behavioral therapy, and this EMDR is a technique that therapists use. It's called eye movement desensitization and reprocessing. These things really help. Do not use benzos. It's contraindicated. It actually interferes with their ability to benefit from therapy. The serotonin reuptake inhibitors or serotonin norepinephrine inhibitors help. Remeron can help with sleep. A lot of people have real bad nightmares. And a medicine that you can use for nightmares is prazosin or mini-press. Start with 1 or 2 milligrams, but you can go up to as much as 10 milligrams. And this usually helps a lot at first. For a lot of people, it kind of loses effectiveness later, but hopefully they're in treatment and it's going to get better. Clonidine and guanfacine can be used, Buspar. Just a real quick on substance use disorders. I tell my patients at Bradford, by the time you get to treatment, your brain chemistry is screwed up. You're going to be depressed and anxious, and everybody's going to be on the emotional roller coaster. And if you've been drinking and using drugs, it doesn't matter what medicines you're on, they're not going to work. So basically what you really ideally want to do is get people off drugs and then a period of time after that before you try to make a psychiatric diagnosis. All right, insomnia. I can't sleep. The medicine I always go to first is trazodone. It's cheap. It's generic. It's been around forever. You can take it forever. I've had people on it for decades and it still works. Start at 50 milligrams. The most I go up to is about 300. The GABA benzodiazepine receptor agonists are Lunesta, Sonata, and Ambien. I've never treated a Lunesta addict, but I've treated plenty of Ambien addicts. And Ambien's the one that people have trouble with amnesia. They do things in the middle of the night and don't remember. Mirtazapine, Remeron is very sedating at low doses. As you increase the dose, the ratio between serotonin and norepinephrine changes. The higher doses are more stimulating for norepinephrine, so it actually is not as sedating as the low dose. Seroquel, a lot of people do well on that. Again, the problem is weight gain. And then there are other kind of classics ones, doxepin, amitriptyline, Belsoma. Check, it's expensive. And one of the things that you can do is if you've used an agent or they've failed on 1 or 2 agents, you can combine them. You know, don't hesitate to use trazodone and Seroquel, or trazodone and mirtazapine. And you can always add in melatonin up to about 10 milligrams. In the interest of time, I'm going to kind of lightly touch on attention deficit disorder. I know that a lot of primary care physicians are asked to fill the Adderall and other psychostimulant prescriptions. And my guess is a lot of you are uncomfortable with that. I think it is overdiagnosed. The symptoms relate to regulating the psychomotor activity has to do with prefrontal cortex that has deficient dopamine transmission. Attention has to do with deficits in norepinephrine transmission. And same thing for inhibitory. People are very impulsive and think before they act. So one of the things that I would really recommend, if somebody comes to you wanting a psychostimulant for a attention deficit disorder that they're convinced they have, if it's an adult, it immediately kind of raises my suspicion, because if it hadn't been a problem that much so far, why are you coming now? A lot of people are going to be asking for the psychostimulants because they want the drug effect, not the therapeutic effect. So before I would start somebody, I would refer them to a psychologist, because there are a number of different tests that pretty much will rule in or rule out a attention deficit disorder diagnosis. And then I would tend to send them over to the psychiatrist to adjust the dose. And once the psychiatrist and the patient have worked out a dose that works, then I would say let's follow you and fill those prescriptions. Yeah. I will talk about the normal people. If they take the ADHD medicines, it looks like they're on speed. It speeds them up, it gives them energy, they will not sleep until it wears off. Whereas people with ADHD, it really does have the opposite effect. That's one of the things I ask people that have been on psychostimulants and think they have ADHD. I ask them, when you take Adderall, does it speed you up or slow you down? Oh, it gives me energy. They don't have it. People who have ADHD, it slows them down, calms them down. It's like they can have one thought in their head and act on that rather than 3 thoughts. A lot of people will tell you they can take Adderall and go take a nap. Normal people won't. They can do twice the work with half of the effort. And if they have to take 2 doses, they have to do something to remind themselves to take the second dose, or else they forget it. Addicts don't have to be reminded. All right, I wanted to cover some of the elderly issues. One of the things is that depression can look like dementia. And the elderly are dealing with a lot of losses in their lives. However, a lot of times therapy is going to do as much or more than medicines for people that are dealing with losses. It's kind of learning how to adjust to those losses. If you do feel like you need an antidepressant, of course you're going to start at a low dose and go slow. And it's a lot of times that the primary care physician is going to hear about the symptoms before anybody else. And what you've got to differentiate is, are we dealing with dementia? And Alzheimer's is the highest incidence. There are a lot of different other incidents. You know, today basically we have about 5 million people with dementia. They're predicting by 2050 it's going to be 14 million. So we got a tsunami coming. This would differentiate between depression, its onset's faster, more rapid progression. They have a lot of cognitive complaints, whereas people with dementia, they don't know. The person with depression is going to have depression symptoms. The person with dementia doesn't realize they're depressed either. And you're going to want to do some basic labs to rule out some stuff that can cause depression or look like the dementia. And treatment, most people recommend that you combine Aricept with Namenta. And most people say start both of them, and basically once you start, you really can't stop if you're really dealing with the dementia. I think one of the things that families will bring their elderly person in for are the behavior problems they're having, especially the hallucinations and delusions. And for depression, you can use regular antidepressants. Do not use benzos in old people, period. They fall, they have cognitive impairment, they get disinhibited. If they're having a lot of agitation and aggression, you can use Depakote or carbamazepine or even prazosin. There's a caution with the antipsychotic medicines for psychotic symptoms because there is an increased mortality among the elderly with dementia. So you need to go over with the family that, we're going to treat the hallucinations, delusions, and paranoid ideas, but Dad might die a little younger. And this is the other thing I really wanted to talk about. It's the patient that somebody else started on benzos and they've been on it for 30 years. And trying to take it away from them is kind of like saying, you can never have a drink of water again. It's like their lifeline, and they think it's really helping them. But especially in the elderly, I tell people if you take benzos for long enough, you will wipe out your short-term memory. You'll get to the point where if you don't write it down, you're not going to remember it. And that's what I try to sell to people, to try to get them off of the benzodiazepines. And I tell them that, look, you're going to look like you have Alzheimer's. And you can get your short-term memory back, but we've got to get you off the benzos. And what I would suggest to people is think about tapering the benzodiazepines over 6 or more months, so a long time. And start either Neurontin or Lyrica at the same time you're starting to taper down on the benzodiazepines. And you start these at a low dose. As you come down on the benzos, you're going to need to increase the Neurontin or Lyrica. And then later down the road, you can think about coming back off. And again, one of the biggest problems with getting off benzos is the rebound anxiety. So you really have to put something in there to help with the anxiety. And I tell people, think in terms of a year off of benzos, and your memory will be pretty much back to what it should be. If somebody's been on a benzo, Boost Bar does not work. Warning, personality disorders. Borderline personality disorder. If somebody comes in and tells you you're the best doctor they've ever been to, watch out, because they're probably borderline, and you're going to do something that displeases them, and you're going to be the worst doctor in the world, and they'll put it on the internet. Narcissistic personality disorders, you can tell them because they know more than you do, and no matter what you do, no matter what you don't do, it's not going to be good enough, right enough, or fast enough, because after all, they're a WebMD. They've read about it on the internet, and they know more than you. Antisocial personality disorders are going to try to con you. I hate to do it, but send it to us. We'll do better. Different things that losses that are people are going through a temporary tough time, or a lot of times therapy will actually work better for them, and they can learn coping skills and learn to resolve their problems. And then last but not least, for all psychiatric disorders, exercise until you die. Exercise treats anxiety and depression and apathy, and it keeps you healthy, and your mind was less likely to have dementia problems. All right. Thanks very much, folks. I appreciate it. I wanted to save a little time for questions, but we kind of ran out here. Any questions real quick? I'll be glad to hang around for a minute.
So in particular, you're saying benzodiazepines are not good for anything, you want to get rid of them? Except for short-term therapy?
Yeah, really short. And even if it's a really traumatic event, you don't want to use it. The years I've practiced psychiatry, I basically don't use benzos. I can accomplish the same thing better with other medicines. And they sure do. I mean, they get people addicted, and about the only good thing I can say about benzos is if you prescribe them, they will come back for your appointment. All right. Thank you.